Talking about CD38 and mainly about daratumumab. As you know already, this is a very important molecule that I think is going to have major changes on the way we approach the treatment of myeloma. But I wanted to just point out that this is one of a number of immunotherapeutic approaches, and I really believe we're on the cusp of a change in myeloma about how we treat patients with a variety of immunotherapeutic approaches. You're well aware that this is happening in some of the solid tumor treatments, a little bit also in lymphomas, but we really haven't enjoyed the fruits of this until recently. Allogeneic stem cell transplant has been around and is sort of now the poor cousin to treatment with myeloma, but it's certainly the oldest form of immunotherapy. The monoclonal antibodies are becoming very important, targeting myeloma directly or working alternatively through a PD-1 pathway. There still is a lot of work going on in vaccines. There's an important trial of vaccines after auto transplant looking at a form of maintenance. There's a lot of work going on in CAR T cells, some of which was reported at ASH. And there are the development of these successors to blinatumomab, which may be able to target myeloma as well. So I think all of these strategies are becoming increasingly important in the future. But we're going to talk about CD38 antibodies. And Joe has told you a lot about daratumumab already. It's worth being aware that isatuximab is another of the CD38 antibodies. It's not yet approved. It has very similar activity, both as monotherapy and combined with other drugs to daratumumab. And I think there are arguments that it may be somewhat less toxic in terms of first infusion, but certainly the infusional toxicities are very similar to daratumumab. Now, daratumumab targets CD38 expression, highly expressed in myeloma cells, but also expressed in a variety of other immune cells, NK and T cells. Actually, the drug works directly against the myeloma cell, direct apoptotic effects, but also immune-mediated through antibody-dependent CDC, APCC mechanisms, but also may affect regulatory cells and actually improve the immunity to attack the myeloma. So this works in a number of strategies. And as mentioned, it's been approved first for monotherapy and relapsed refractory myeloma due to high level of single agent activity, but more recently it was approved in combination with IMiDs and dexamethasone and proteasome inhibitors based on rather impressive data that I'll review very briefly. Now, the monotherapy is based on this combined data. These were almost 158 patients with very advanced myeloma. These patients had been heavily pretreated with 5 or more lines of therapy. As a monotherapy, this had a pretty significant response rate, 31% overall response rate, with about 15% VGPRs or better. But it's also worth pointing out that there was a very significant population, better than 50%, that achieved either a minimal response or stable disease. Ordinarily, you'd say that doesn't mean much if you don't get a response. But in fact, when you look at survival and progression-free survival, this is the overall survival. Obviously, the best group is the top curve, where these patients achieved a PR or better, the typical responders. But if you look at the middle curve, these are the patients who are only MR or stable disease, and they had an 18-month overall survival, median survival. And that's certainly much better than the non-responders. So this drug, while it may not produce CRs or VGPRs or PRs in everybody, can in some patients have a meaningful and prolonged effect, even as monotherapy. Now, there were 2 large trials previously mentioned, the Pollux trial, which was a comparison of lenalidomide dexamethasone versus a triplet with daratumumab. This trial, patients were randomly assigned between the two. These are patients that had failed one or more therapies, a less heavily pretreated population than the single agent therapy group, but a very impressive increase in progression-free survival compared to RD alone. And this is one of the trials that led to approval of this drug. Now, the response rates similarly were much, much higher. Overall response rates, 83% versus 79% for the RD alone. Now, the daratumumab was also studied with bortezomib and dexamethasone. This trial was a little bit different, and it's important to keep that in mind. Patients received 8 cycles of bortezomib, dexamethasone with or without daratumumab. The patients in the daratumumab arm continued on daratumumab, but nobody got bortezomib dex after 8 cycles of therapy. So in fact, the bortezomib dex arm alone these patients had nothing after the first 8 cycles of therapy. Obviously, the triplet won out over that, but if you look at progression-free survival, it's not as robust, 7.2 months for the BD bortezomib dex arm versus about 18 months in the lenalidomide dex arm in the Pollux study. And I think part of it was the patients stayed on therapy, and here these patients dropped their therapy in the comparator arm. Now, in that study, the overall response rates were better, 83 versus 63% overall response rate, with a significant difference in VGPR rates. And then also the other thing that was interesting was the incidence of MRD negativity. There's been a lot of talk, as you know, about MRD and its impact on outcome, and in myeloma, as in the other diseases, MRD negativity does correlate with much better outcomes. So this looks at the combination. This was presented recently at ASH in the relapsed refractory population for the Pollux and Castor studies. And this looked at MRD negativity based on either 10 to the minus 4, 10 to the minus 5, or 10 to the minus 6 MRD negativity. As you can see, comparing the daratumumab RD versus the RD group, the highest levels, 11.9% overall versus 2.5%. And in the Castor study, it was 4.4% versus 0.8%. But in every level, adding daratumumab to the combination improved MRD negativity. When you looked among the CR patients, it was similar. 10 to the minus 6, 26% versus 13%, 16% versus 9%. Now, one of the interesting observations also in this was when you looked at the high-risk cytogenetic group, none of the relapsed patients in the high-risk cytogenetic group achieved MRD negativity with either bortezomib dex or lenalidomide dex, while 18 and 14% that had the daratumumab achieved MRD negativity. And I think this is a clue to us about why high-risk cytogenetics are so difficult in terms of controlling the disease. These cells inherently seem to be more resistant. The interesting thing is daratumumab may be agnostic with that and may be able to target these cells to some degree that we couldn't formally achieve. So I think this is very important. When you looked at the PFS for these patients, it was more than 90% if you achieved MRD negativity. And that was actually regardless of whether you got daratumumab or not. Even in the RD or BD groups that didn't get daratumumab, if they became MRD negative, they had an excellent PFS. And so this is an important drug added on to our treatment, and I think we're going to see this used more and more. Now, one of the problems is infusional-related toxicities. As Joseph said, this drug is associated with a lot of infusional toxicities. These are data taken right from the package insert looking at this. So almost half of the patients had some degree of infusional toxicities. Fortunately, most were grades 1 or 2. Only a small percentage were grade 3. The other thing to note is that these infusional toxicities occur with really mainly the first dose of the drug. Second and subsequent infusions, the rate of infusion reactions go down markedly to 5% and 4%, and none of them were grade 3 in subsequent infusions. These occur usually within the first 4 hours of therapy, usually a median onset 1.5 hours. They do require sometimes interruption of the infusion, and as a result, the first infusion can take a long time, 9 or 10 hours. Fortunately, the really severe reactions, bronchospasm, dyspnea, hypoxia, hypertension, occur very infrequently with about 2%. More commonly, patients complain of nasal congestion, cough, allergic rhinitis, throat irritation, minor dyspnea, and nausea. Now, you can minimize these reactions with pre-meds, and all of these are given usually for patients: acetaminophen, diphenhydramine, methylprednisolone, or montelukast. One of the ways you can kind of deal with this and avoid these long infusions is to split the dose into 2 doses, and I will do that for some patients. Give half the dose one day and half the dose the next, and that way the patient is not sitting in your clinic for 10 to 12 hours. Another approach is simply to give a half dose as the initial dose, and then a week later you can give them the full dose. Again, usually with a reduction in the side effects. Obviously, these are off-label recommendations. These are not things that you can read from the package insert, but they are strategies, I think, that can minimize some of the difficulties with the first infusion. Now, Joe alluded to the subcutaneous administration of the drug. This is the so-called PAVO study, and in that trial, they used subcutaneous daratumumab with a recombinant form of hyaluronidase, which can break down the tissue and promote the absorption of the drug. And so this trial looked at 2 doses, 1,200 milligrams subcutaneously, or 1,800. 1,800 milligram is closer to the 16 milligram per kilogram dose that's recommended. These were patients given monotherapy, 53 total, only 8 in the low dose and 45 in the higher dose. They had failed 2 or more lines of therapy. Again, it was monotherapy. They got the standard cycles of treatment every week for 8 weeks, then every other week for 16, and then weekly thereafter. Again, these were heavily pretreated patients, 5 and 4 lines of prior therapy. These patients were refractory to the last line of therapy, 88 and 71%, and most were double refractory. So when you looked at this, most of the patients in the small number of 8 who discontinued treatment did so for progressive disease. In the higher dose, only 27% had discontinued treatment. But keep in mind, the follow-up is very short. This was reported at ASH, and the median follow-up was 6 months in the low-dose group and 4 months in the higher dose group. So when they looked at the PK, they were similar to the 16 milligram per kilogram in the higher dose group, and in terms of area under the curve, it seemed very similar. So it looked like giving it subcutaneously was not associated with any difference in how the drug was handled. And looking at the overall response rate, these responses are very much in line with monotherapy, 25% at the lower dose, 38% overall response rate with the higher dose, and then a number of patients, 50% and 38% with stable disease, 13 and 11 with minimal responses. So in terms of efficacy, that seemed very similar. When they looked at SAEs, there were common SAEs, but they were all along the typical profile that you see with intravenous daratumumab. So giving it subcutaneously didn't seem to affect any of the typical toxicities and the grade 3 to 4 treatment-related toxicities. However, when you looked at infusion-related toxicities, these did seem to be lower. So overall, looking at the higher dose corresponding to the 16 milligram per kilogram dose, only 24% of the patients experienced infusional-related toxicities, and this compares with 48% with IV. These were similar things: oropharyngeal pain, paresthesia, rash, sinus headache, vomiting, wheezing. Only one grade 3 infusional-related toxicity was seen at the 1200 dose, and there were no grade 4s. So this could be a promising approach for giving this drug that may avoid certainly some of the infusional-related toxicities that are seen. Ultimately, it would be much quicker because you can give this over 30 minutes and avoid the prolonged infusion of this drug. So they concluded from this that subcutaneous administration with the recombinant hyaluronidase was safe and effective. There were dose responses similar seen at the intravenous dosing, and the AEs were similar with a low incidence or a lower incidence of infusional-related toxicities and similar pharmacokinetics to the intravenous dosing. So in summary, daratumumab is a new anti-myeloma drug, class of drug, the CD38. It's active as monotherapy in relapse refractory disease, and it shows clear synergy with bortezomib dex or lenalidomide dex. I would also point out that there was data presented at ASH using it with pomalidomide dex that looked very similar, and data presented with carfilzomib and dex. So it can be combined with any of the classes of proteasome inhibitors or IMiDs. The drug is generally well tolerated, and the infusion reactions are mainly with this first dose. Joe alluded to some of the future things that are going on. It's going to be combined as upfront therapy. It already is in several trials. I think we finally have an R-CHOP for myeloma, and I think that's going to have a major impact on the disease course. But it's also being studied in maintenance therapy, and it's being used to look at some of the high-risk smoldering patients as a way to avoid progression to active disease. And with that, I think I'll stop. Thank you for